difficult situation to see your child struggling with vision, because most of the time they are not aware themselves, and it's very, very important to address these problems early so that we can prevent a lot of other problems which are vision dependent in future. So each child has specific visual milestones, and it's very important for us to know these so that we can pick up these problems early on and treat them early. So pupillary light reaction can be seen at 30 weeks. They generally give eye contact by 2 months of age. Contrast sensitivity develops by 7 months, and child can have 6/6 vision on Snellens by 5 years of age. So vision impairment in children could range from no vision to low vision, and we'll divide it into visual impairment in infants and older children. So when do we say that vision is not normal? When we are seeing wandering eye movements or visual inattention, lack of response to familiar faces and objects, there's no eye contact, if the child is staring at bright light or eye poking, or there's nystagmus, involuntary eye movements, and if the vision is not 6/6 over 6 years of age. So it requires a thorough workup, and history is very important here. So need to know the onset, severity, and progression of vision symptoms. Look for antenatal history, where you need to rule out if there is maternal infection, any trauma, diabetes. Postnatal history of prematurity, low birth weight, seizures, any neurological issues, any medical anomalies. Family history is very important. Rule out any history of consanguinity. Prior use of spectacles, LVA, difficulty with near task and mobility, and also ask for any difficulty the child has in day to day activities and what impact it has on the child's well being and the psychosocial functioning. In infants, look for lack of eye contact with the family members, photophobia, eye poking, and squinting. And in older children, you may see that child may be holding the reading material very close to their face, rubbing their eyes, or adapting abnormal head posture or intermittently closing one eye. They may also have history of night blindness, squinting, and some children might be very clumsy. They may knock over things and trip often. Coming to the ocular examination, look for fixation and falling of light on objects, response to the visual stimuli like face and toys. Quantify the vision according to the age appropriate chart, and also taking into considerations the child's cognitive function. Pupillary examination must rule out any RAPD. Look for nystagmus and oculomotility disorders like Duane syndrome or congenital oculomotor apraxia. Very important to look for color vision, because many a times when the color vision is absent, child may have difficulty with recognition of objects. So we can utilize Lia puzzles or colored matching balls or Nishihara's test. Similarly, contrast sensitivity is very important, because sometimes the child may have normal vision, but because of poor contrast, they may have difficulty. So hiding Heidi test or Pelly-Robson's test can be used. Dynamic retinoscopy is very important to look for any accommodation lag. Visual fields in children can be assessed with Lia wand or smiley faces, and in older children, we can also do confrontation or Humphrey's visual fields. A detailed dilated slit lump examination is very important to look for any anterior segment pathology. Again, coming to retina and optic nerve, rule out any optic nerve pathology, foveal hypoplasia, or retinal pigmentary changes. Cycloplegic refraction is a must, because many a times refractive errors are missed out. And wherever necessary, one may have to do a post-Mydriatic test. So when you're looking at a examination in infant, if the examination abnormal, if the external examination is abnormal, you are either looking at microphthalmos, aniridia, albinism, cataract, or glaucoma. And if the external examination is normal with or without nystagmus, and if the fundus is normal, you can utilize ERG. If the ERG is normal, you are either looking at a congenital infantile nystagmus or congenital oculomotor apraxia, delayed visual maturation of cerebral visual impairment. If it is abnormal, you know that you might be probably looking at LCA cone dysfunction or retinal dystrophies. When there's an obvious abnormal fundus, you need to look for any pathology in the vitreous, retina, and optic disc. So let's look at this chart. If you're looking at an apparently blind infant who has infantile nystagmus, look for any anterior visual pathway disease like bilateral optic disc abnormalities. If it is there, you need to rule out any supracellular tumors, hydrocephalus, or any disc anomalies which could be coexisting with CNS abnormalities. If that is absent, then look for photophobia, high myopia, paradoxical pupil or ocular digital signs, which could be suggestive of a congenital retinal dystrophy. Here the ERG could help. However, if the ERG is negative, you're looking at an infantile idiopathic nystagmus or a neurological nystagmus. When the infantile nystagmus is absent, one should look for saccadic eye movements, and this can be elicited with vestibulo-ocular reflex. Now, if that is normal, you should also look at history of prematurity, perinatal hypoxia or abnormal neuroimaging, and seizures. And all this, if it is positive, could also be erring towards cerebral visual impairment. When all this is absent, you are probably looking at a child with a delayed visual maturation. When the vestibulo-ocular reflex is absent, we are looking at a congenital oculomotor apraxia. So this is a video of a child where you can see that the child is having difficulty in eliciting saccades, and child is using a head thrust to look into the lateral glazes. Often these children could have a delay in motor and speech. So when you're looking at poor vision, no nystagmus, normal eyes, there are two things which we need to keep in mind. First is delayed visual maturation, because the neurological status is normal here. The ERG will be normal, flash and pattern VEP will be normal, MRI scans are normal. So visual outcome is generally good, and it improves over 3 to 5 months of age, and this is generally a retrospective diagnosis. Other entity that one should keep in mind is cerebral visual impairment. This is a spectrum of in this spectrum, the child could have limitation ranging from low to high functioning. In low functioning, the vision is generally poor. They can have a stormy perinatal period, and HI is the commonest cause. And abnormal neurological status like global developmental delay, seizures, and cerebral palsy, etc., is seen. MRI scans are abnormal, like hypoxic ischemic encephalopathy changes or periventricular leukomalacia can be seen in these children. So when you're looking at an older child, if the external examination is normal, so either you're looking at a functional cause, refractive errors, or something like a retinal dystrophy. Also, cerebral causes should be ruled out, and look for optic nerve issues. When the external examination is abnormal, rule out any anterior segment pathology in the cornea, lens, and also look at glaucoma changes. Wherein in the posterior segment, you need to look at obvious changes in the retina, vitreous, and the optic nerve. Other investigations like ERG and VEP could help. It is important to have consultation with pediatrician, pediatric neurologist based upon the causes. Neuroimaging studies may help for CNS and optic nerve lesions. So it's not just what the child is seeing, but it affects a lot of other aspects of the child's development, like communication, playing and socializing, talking, telling the difference between day and night, sitting, crawling, walking, learning to read and write, playing. So what is the best thing that we can do for this child? Early intervention. So correcting easily treatable causes like refractive errors, cataract surgery, providing them vision therapies, educating the parents and the child, and also additional supports would help. So helping parents learn how to bond with the child and interact with them in a way that supports their development. And also it requires a multidisciplinary approach. Thank you.
Thank you, doctor, for taking us through the various developmental this thing. But what we have to remember is not to tell the parent, even when you obviously see some this thing, that don't abruptly say that child cannot see or something like that. As far as CVI is concerned, because there are other multiple pathways which can
Yeah.
help the child see. And whenever you have some this thing when you ask for a MRI or something like that, they would have done at 1 month of age or something like that, immediate. So in that case, it won't show any abnormalities. It will be normal. So you may have to repeat the imaging sometimes to pick out this thing. And the other thing
Yes.
is hypoglycemia.
Yeah,
That
hypoglycemia.
history also is very important. That also
Yes.
can lead on to
Yes, yes.
this thing.
Yeah, I mean, your delayed visual maturation is a very important thing.
Yes.
You have a lot of children coming who are not, maybe who are a little beyond their milestones. I mean, so they get your VEP done, there's abnormal, and you suddenly start, it's like an alarm reaction. I mean, what's happening? Why is the VEP? So these have to be tackled very carefully. I mean, repeat VEP is very important in these cases. Many a times when you have these developmental delays, a repeat VEP would be normal.
And I think
So
close follow-ups would also help,
yeah, I
so
mean,
that
so
we
the
know that
the
they are
child would start developing. I mean, it's a delayed
yes.
milestone. He would start developing
Yes.
other and the a little later. So the visual maturation would also be a little delayed. So all these things, I mean, it's the counseling when the parents are very bothered about my child is not seeing clearly. So the counseling is very important, and getting having a right approach and follow-ups. Probably one stop diagnosis is not the right thing in these patients. I mean, you need to have these children under follow-up to exactly know what's happening before you come to a conclusion.
Yeah, absolutely. Thank you.
Please remember, they're going to become myopic, and you have to give them glasses because they are a high risk of amblyopia as compared to a normal child who you might not give myopic refraction in the when he's an infant. So in these preterm babies, you need to get in early and start the treatment to prevent amblyopia.